Hi everyone, today I'm here with Dr. Chima, a family medicine and sports medicine doctor in the Sacramento area who's been practicing in the field for over 9 years. So thank you, Dr. Chima, for being part of this interview.
Yeah, thanks for having me.
And so before we go kind of into the details of family and sports medicine, could you briefly describe what family and sports medicine are and maybe some of the most common cases in each of them?
Sure. So family medicine is kind of the jack of all trades when it comes to the field of medicine. You see everything from the cradle to the grave, so pediatric patients, adolescents, teens, middle age, all the way to geriatrics. You don't really have 100% specialty in just one focus, but you have a good generality of many different specialties. So for family practice, you take care of everything from immunizations, well child visits, annual wellness visits, a lot of preventative care, in addition to acute care visits, so cough, cold, pneumonia, cellulitis, skin infections. And then you manage a lot of chronic conditions such as diabetes, heart failure, chronic kidney disease. With sports medicine, the focus there tends to be more in the athletic-based population. So you do a lot of on-the-field care, so sideline physicians for high school games or different sporting organizations. You tend to do a lot more musculoskeletal examinations, so a lot of intraarticular injections, casting for fracture care. That extra 1 to 2 years of fellowship kind of trains you and prepares you to do a lot more than the generalities of family practice. The good thing about the two of them combined is in family practice, there's a lot of musculoskeletal conditions, back pain, shoulder pain, hip pain. And with the sports medicine background, you're apt to take care of that without having to refer out to orthopedics.
Okay, and why in particular did you choose family and sports medicine as a fellowship?
So family medicine, quite frankly, when I was going through before residency in medical school, I really didn't know what I liked. I kind of dibbled and dabbled in everything and never really found one thing that stood out to me to say, hey, it's the heart and I want to specialize in just the heart. I kind of found a good general broad interest in everything I did. So family practice made good sense, and the fact that I could do everything. The lifestyle also was a big part of my decision. I knew I didn't want to work 24 hours on call. I knew I wanted to be outpatient and have a good family life. And so with family practice, you have the leniency to go ahead and do whatever hours you want to, particularly in private practice. So it lends to more productive social life outside of the field of medicine as well. Sports medicine, I've always been very active growing up and always loved sports. And during my time in residency, I had a attending who was a sports medicine physician, and he's the one who actually introduced me to the field of sports medicine. And so I just thought the two would go hand in hand pretty well, one able to cherish off the other.
And so sports medicine is a fellowship you can do, a subspecialty of family medicine. What other subspecialties or fellowships can you do in family medicine? Maybe what are a few of the cases you'd see in each of those?
So with family medicine, there's a couple other specialties you can do. So you can be a geriatric specialist, in which case you're doing more nursing care homes, 65 and older population. You can do hospice medicine, in which case now it's more end-of-life care, so managing those patients who have 6 months or less to live, whether it be from terminal cancer, end-stage heart disease, or COPD. There's also OB/GYN track you can do off of family practice. So if the GYN model is something that you want to specialize with as far as taking care of people who are pregnant, deliveries, LEAP procedures, then you can do a FP OB/GYN tract as well.
Okay, so it seems like there's a lot of different avenues you can take the family medicine specialty into. How do you divide your practice between family medicine specific cases and then sports medicine? Is there a certain percentage like 50-50 or 75-25? And then are there certain subsets of the population that you focus more on or that you don't focus as much on? Yeah,
so big question. So as far as in practice goes, everybody's varies. Depends on location and how you want to run your own practice. Me personally, we're probably more 70-ish% primary care, 30%-ish sports med. As far as patients, a lot of our sports med patients typically are our family medicine patients already, who are just happen to be active and get hurt or get referred from outside providers into our office. I take care of William Jessup University, and we do a lot of concussion care, so we get a lot of outside referrals just for concussions. But half a day a week on Wednesday afternoons, I'll go to William Jessup, and there I'll just see training room hours where we'll just take care of whatever injured athletes there are at that time. So It's not a real good estimate, but about 70-30 is kind of the average split. I would say, at least for our practice here, we tend to be more that adolescent to 65 population. We don't have as much of a pediatric population, although we still see newborns and children under the age of 12. But I think the vast subset tends to be more of our adolescent to middle-aged. We have a fair share of geriatric, the growing population, and I think in family medicine, you just can't get rid of that, which is not a bad thing because it's definitely a booming population. But preventative care and decreasing cost of care, having a good primary care provider can really help to improve longevity of life and decrease morbidity and mortality.
And so is that by choice, or is there a lot of flexibility in family medicine to choose whatever populations or types of cases you want to see?
So with family medicine, the good thing about it is you have the breadth to take care of anybody from cradle to the grave, but you can choose to gear your specialty or your practice how you want to, and how you market yourself out in the public is typically how you're going to go ahead and gain those patients. Typically with family practice license, if you're advertised just as a general primary care, then you'll get all walks of life coming into your clinic. But if you go out to the local high schools and if you're marketing more towards the GYN and how you advertise amongst your own internal patient population, then you'll sub-select into whatever group you want to.
Okay, so there's a lot of ability then in family medicine, which is great. So moving on to lifestyle, could you walk us through a typical day in your life from when you come in to when you leave, and if that changes throughout the week?
Typically, so I start early. So we'll start office around 7 o'clock in the morning. And then we typically will just go straight on through until about 2 to 3 o'clock-ish, sometimes taking a lunch, sometimes not taking a lunch. But I choose to do that on my own, just so that way I can get out early, and then I can go spend time with my kids. They usually get off of school around 4 o'clock, so that way I want to make sure I'm home with them to help them out with the school. And so I try to get much of my charting that I can done when I'm seeing the patients during the day. So most of the time during the office is just seeing patients. In between patients, it's a lot of triage. So my medical assistants will tell me if there's an urgent issue to be addressed, such as a patient call, another doctor calling in about a patient, or critical labs. In between patients, we're also trying to manage our in-basket, which is a growing beast in the world of medicine. And I don't think there's a really right answer how to target or tackle the in-basket, but you try to handle as much as you can in between patients, but a lot of that's left for after hours to finish up in between. But usually I'll try to get to the gym early in the morning to start my day, and then by the end of the afternoon I'm with the family, coaching soccer, or hanging out with the kids.
Is your lifestyle or your typical day different from other family medicine doctors, or is it pretty similar?
Yeah, so even in our own private practice here, we have 2 other MDs, and we have 3 nurse practitioners and a PA. And so my other 2 partners start at 8:30 and they finish at 5, and they take about an hour and a half lunch. So typically from 12 to 1:30. And that's usually the average hours of a typical FP doc, but it can vary depending on your productivity. If you want to see more patients, you can extend hours. If you don't want to, then you can shorten your hours, but in that you're going to change your overall productivity and how many patients you're seeing.
Okay, and how is a family medicine lifestyle different from that of like surgeon or another specialty?
So I think in general, family practice lifestyle tends to be somewhat a little bit less stress. You're not having to worry about doing anything inpatient. We still do procedures, incision drainage, sutures, injections, but the level of risk is less, and so you don't have to worry about being in the hospital and running back and forth between 2 different settings. There's no overnight hours or overnight calls per se. We're going to go to the hospital. We still take phone call for our patients, so that way if they have after-hour emergencies, they can get a hold of us, but it's totally based off a phone, and we share call. So with me and my 3 partners, we cycle every 3rd day. So I would say just in general, it tends to be a little bit less of a stressful environment.
Kind of moving on to other aspects besides non-clinical work that you do, it seems like you're involved in so many other projects. Could you talk about a few of the other things that you do besides just like clinic work? And what are tips that you'd recommend for family medicine doctors to get involved in these other things besides the clinical sphere?
Yeah, so I mean, in general, you can live your whole life just doing clinic day-to-day practice, living a 9 to 5, and be totally fine. But there's a growing worry about burnout, and so my biggest advice to anybody is if you have a certain passion and you want to diversify your day-to-day practice, then you should go ahead and do so. Whatever drives your passion, that way you'll stay in practice for a lot longer period of time. And I think it's a benefit of the greater population if you have a provider giving care for 50 years versus doing a lot of care, but just for 5 to 10 years before they burn out. So personally, I'm involved in a startup company called Protex, and it's a medical wearable device that we use to monitor patients' balance, using it on the field to sense head impact for concussion safety, and also using it in elderly people as a fall risk assessment tool. And so that's still in its early stages, but so far it's been gaining pretty good traction. We have a separate concussion medical clinic. I'm working with the pediatric neurologist, and so with my sports medicine background and dealing a lot with concussions, we were able to open up a separate clinic where we just focus on concussions as well. And that's just a part-time clinic, so it doesn't take all my hours, but it's usually 2 to 4 o'clock in the afternoon, 2 days a week, if we choose to open. Then I'm also a medical director for Sutter Independent Physicians, and in that role I deal with quality, and so it's a lot about education to all the other independent providers in our practice as far as what quality metrics we're tracking, how that can improve patient care, but also how that funnels into reimbursement dollars to the physicians as well too. And then lastly, I'm also a physician champion for the electronic health record that we use called Epic, and for our Sutter patients and our Sutter providers under Sutter Community Connect, I'll go out to the providers and help educate them how they can be a little bit more in tune with their EHR and how to optimize their overall utilization.
Okay, and what tips would you give for family medicine doctors maybe new ones starting out to get involved in like different things like these?
I think the biggest thing is find out what you like to do and just ask if you want to be involved, whether it be medical directorship, EHR champion, starting a tech company, being a medical director there. You really should just use your medical license to the fullest, not being afraid to ask and say, hey, I want to be involved. Often there's plenty of opportunities, and a lot of people just don't want to bother you because doctors are busy enough in general. So sometimes just vocalizing that, hey, I've got a certain interest or a certain avenue I want to succeed with, and then pushing down that direction.
And what's the most challenging aspects of both family medicine and sports medicine?
For family medicine, I think end-of-life care is probably the hardest thing to come to grasp with. The beauty of family medicine is you tend to have a good longevity of care. Patients may go out to the specialist and see them for a particular issue, whether it be heart failure or kidney disease management, but they always come back to their primary care, and they're always asking for guidance. You tend to see them on a once-a-year basis. You get to know them, but also their family. And then when it comes to end of life, nobody knows that patient better than the primary care doc, and sometimes you have to know when to say enough's enough. Because right now in medicine, we have so much technology and advantages to us, we tend to prolong life without improving quality. And I think that's the hardest part, is to have those conversations with your elderly or end-of-life patients, and to try to do it in a tasteful manner, but also at the same point in time, not to allow that emotional stress to overcome yourself as a provider. In the sports medicine world, I think it's season-ending injuries. That tends to be the hardest, because often people are putting their passion into the sport and something they're training with year on, over and over again. And if they tear an ACL and it's the midst of the season, or if you have a bad ankle injury and we're going into playoffs, how do you tell a patient to shut down? And often that initial conversation may be a hard conversation to have, but explaining with them what's going on and having them come back in for the follow-up, and having them trying to see outside of the sport's eye what's going on, and how we're trying to make sure they don't hurt themselves for the rest of their life by pushing through an injury when it's not in their best interest.
On the flip side, what would be the most rewarding aspects of both family and sports medicine?
So the rewarding aspect, particularly for family medicine, is if you take somebody, or if you inherit somebody as a patient and they have severe uncontrolled hypertension or diabetes, and to get that patient to internally realize what may be the problem, trying to do that problem-solving techniques with the patients and playing detective, and being able to find out, well, hey, what's the problem? Let's go ahead and make the diagnosis. Let's try to treat that problem. And then when they come back, you're able to see, is there improvement? I think that's the rewarding part, because our whole goal with primary care is to be as preventive as we can and prevent long-term outcomes like diabetic amputations or hospitalizations. So when somebody comes into you for distress, and if you're able to see that patient, triage them appropriately, get them into the right hands if need be, or manage them yourself, and then show good outcomes afterwards, I think that's pretty darn rewarding, knowing that you're doing a good job. From a sports standpoint, it's quite the opposite. It's kind of keeping them on the field. So those patients who come in, whether it be a dislocated shoulder or some sort of ankle or concussion injury, and being able to walk them back and progress them back safely back into return to play at an optimal level, I think that always gives everybody a fair amount of enjoyment when you get them back on the field.
Are there any misconceptions about family medicine or sports medicine?
I think a fair misconception is that primary care or family practice is probably it's not as a sexy of a position as a specialist, and so a lot of people tend to want to go into the specialty field because they feel like, I don't want to have to deal with everybody's problems. I just want to know what that one issue is and know that one issue very well, and then I'll farm that patient back to their primary doc because the rest of it's just too much of a headache. But there's headaches in every field. So depending on whatever specialty you go to, you're going to have your own headaches. But I think a lot of people tend to think that family practice is more of a headache with less of a reward. But I think now with the growing demand on preventative care and quality of care versus quantity of care, there's a growing demand to increase our overall primary care provider roles in the community and opportunities. And so there's a lot of financial reward in being a primary care provider. So you can live a very lucrative life being a family practice provider, but sometimes without as much of the headache or as much of the stress. I think just depending on whatever avenue you go, it's just a different version of stress. So I think often people tend to feel like family practice may not be a great lifestyle or a great moneymaker, but often they're just misled. Sports medicine, I really haven't heard too many people have much in the way of any misconception. It is what it is. It's the field of medicine dealing with sports-related injuries. The only issue is that you can use that for non-sports-based patients. So we tend to get a lot of utilization in the primary care world. So I think using that in addition to a sports medicine title, but utilizing it in your primary care role really just amplifies your overall use in practice and availability without having to farm patients out to specialists.
What personality types would you recommend or would you say are best suited for family medicine and or sports medicine?
Personality type-wise, ideally like somebody who's laid back. Need to have a bit of patience when you're in family practice because you're going to deal with a whole host of medical problems, and sometimes there are multiple issues that come to fruition in one visit. So somebody who has more of a laid-back personality would probably thrive in a family practice setting. Sports medicine, you don't have to be athletic per se. You don't have to participate in all the sports that you're treating, but you like to be more of an athletic mind frame. Athletes are a little bit different when it comes to injuries and return to play. They tend to be more aggressive in their rehab and on their course of treatment. So people who are of that more aggressive mindset tend to do better in sports medicine.
And what tips would you give medical students to match into a competitive family medicine residency and then residents to match into a competitive sports medicine fellowship?
So tips for admission. So I think this is a great question. How do you make yourself a competitive applicant? I guess the first thing is making sure you do rotations, and since it's a core rotation for family practice, that checks the box, but you probably want to go back and do a secondary rotation. The more experience you get in dealing with totality of care, so if you have volunteer experience, homeless shelters, women's care organizations, and a broad breadth that shows that you're willing to take care of anything from the pediatric population to the older generation, that typically will improve your likelihood of matching into family practice. Obviously, you need to do well on the boards for anything just to get matched, not just for family practice. And then just having strong letters of recommendation, particularly from providers in primary care, whether it be internal med or family practice, but particularly in outpatient setting. And out of those letter recommendations, typically family practice residencies like to see a well-rounded individual. They want to see somebody who has the ability to cope with high stress as far as multiple patient problems coming their direction. So if you can get that tailored into your note, then show the volunteer and work experience behind it, then that'll boost your chances. For sports medicine, you really need to show there's a reason why you want to be in sports med. So you need to show that, hey, I've gone to shadow a sports med doc. I've done on-the-field training, so go do high school coverage, go do a junior college and cover that team with the appropriate physician at that time to gain hours in experience. So that way it shows the motivation and drive. And then ideally for family practice or sports med, if you can do some sort of poster publication or some sort of paper publication, that definitely will help to boost your resume as well.
Okay, and moving on to more of the financial aspects or business aspects of things, how well are family medicine physicians compensated generally, as well as sports medicine physicians, if there's like a pay increase for specializing? And would you say this is a fair compensation, since primary care physicians are thought to be maybe like the lowest compensated stereotypically?
Yeah, so I guess it also depends on if you're working in a private practice setting or if you're working in a larger organization, such as an HMO organization. I would say that primary care in general is actually compensated pretty well. And I think the compensation model has shifted more towards primary care, so there's a little bit better reimbursement for the amount of time and effort you placed in. If you go to certain organizations, there's sign-on bonuses, so that's something you want to take a look for, see if there's loan forgiveness, because that also obviously is a big factor, particularly for primary care if you're practicing in a rural-based setting or within a larger HMO organization, because they're definitely struggling to find primary care providers. In private practice, which I'm biased because I'm a private practice doc, is very financially rewarding. You're basically getting reimbursed for the patients you see without paying for the overhead. And there's a lot of quality metrics associated with primary care outcomes, and those directly correlate into incentives or drive a bonus back into your office setting and then back into your wallet at the end of the day for providing good patient care. Adding sports medicine to your title doesn't really necessarily increase your overall pay grade per se. However, you're able to do a lot more procedures. So injections, you're able to do a lot of concussion care assessments, do impact testing, which is a neurocognitive test, fracture care. So stuff that perhaps you'd be referring out and paying and having the patient pay somebody else to do. You're actually able to do that yourself and charge the appropriate codes for the interventions, which help to increase your overall reimbursement. Mm-hmm. So I would say you're definitely not getting paid the highest of the scale, but you're definitely not on the lowest by any means. And there's more than enough to make a healthy living.
Mm-hmm. And are there certain things you can do or ways you can increase that income?
So other ways you can increase that income would be adding on extra positions around it. So medical directorships, which don't involve a whole host of time. So sometimes you can be medical director for a home health agency, physical therapy organization. You can do quality directorships within independent or insurance-based organizations. There's definitely the admin role, administration, and a lot of primary care docs tend to go into administration as well too, because you're well versed in seeing everything in the patient's care. So it does prompt you put you in a role for administration. So there's different ways to increase your pay outside of that network as well.
So it seems like there's a lot of opportunities, especially in family medicine, to work in different employment settings like locums or a big group, a small like independent physician, and different areas like that. Why did you choose private practice, and what would you recommend people to get into? Like, would you recommend they work with a big group first and then do more like small independent things, or try out locums for a few years, or what are your thoughts on that?
So for me, independent or private practice, it was pretty much a no-brainer. I like to have the flexibility of life. I've got 2 small kids, and so when I was starting off, my kids were almost 1 and 3, and so I wanted to spend as much time as I could with the kids, and as they grew, I want to make sure I have enough time for them. And so private practice, I can make my own hours. So I coach the soccer team, so whatever days I want to have soccer practice, I can make sure I cut my own clinic down on those days so I can make time for the kids. On days where we have free time, I can increase my hours. If a day I don't feel well, I want to call in sick, I don't have to worry about it. I can call in sick. If I want to go on vacation and do a CME with the family, I don't have to answer to anybody. I just have to tell my staff this is the day that I want off, whether it be tomorrow or a month from now or a year from now, and I can set it in stone and be done. And there's no reporting to anybody else above myself or my partners. And And so with private practice, there's a tremendous amount of flexibility that you often don't get when you're working in a larger organization. You may be allowed certain time off for sick leave and vacation, but often that has to pass through somebody else's cadence to say, yeah, you're okay and approved. And even then, when I feel like when you're a provider and a physician, you like to make your own treatment decisions. And we're all hand-tied a little bit when it comes to insurance, as far as what we can and cannot do and what the patient may or may not be allowed to do. But in private practice, you don't have to worry about the administrative burden of anybody else regulating or restricting your hours that you can work, the days you have to be on, your medications that you're giving, because all that quality and incentives are driven within yourself in your own practice organization, and you can shape it the way you want to. So I think being in private practice gives you a lot of your own flexibility, but your own direction, and you can have that fluid ability to change as quickly as you want to. So if there's a new metric that pops up, well, it happens on Monday, you can change on Tuesday and see the change by the following week. Whereas in the larger HMO organizations, you don't have as much of that flexibility. There's a lot more administrative burden that may be on top of the employee. And when you work as an HMO, you are an employee in that organization, so you may have some say in some committees you can sit on, but you're still, at the end of the day, employed for somebody else. And so all the extra work you're doing, there's other people who are taking money off the top in order to pay the bills, keep the lights running, and pay for the rest of the admin cost. So I would definitely kind of put that into people's minds when they're thinking about where they want to practice and how they want to practice. Particularly here in Northern California, we have a lot of big HMO organizations, but private practice by all means is not dead. And then if you go down south, go back east, there's a lot of private practice clinics. And even here in the Sacramento region, we're thriving really well. It's just a matter of having that extra initiative. When I first started, I have no private practice experience. I literally, after fellowship, this is my first job. So there is some learning curve that comes with it, and I think that's what scares a lot of people out of private practice. But just getting your feet wet and asking, there's a lot of independent organizations where you can get a lot of information and shake hands and find out what people have done right, what they have done wrong, learn from those mistakes, and then grow your own business. So for me, I'm totally biased, but I would say private practice all the way.
Okay, and so part of work-life balance, which I was going to talk about next, is being able to manage your own schedule and having that flexible schedule. Is there anything else that you do that to kind of establish that work-life balance?
Yeah, so I think exercise, so being a primary care and a sports med doc, I preach exercise quite often, but I take it to heart. So usually in the morning, I'll try to do some time by myself or wake up a little bit earlier before the kids get up and try to get to the gym for at least an hour, 5 days a week. I think that's super therapeutic. And I recommend it when you're in medical school, when you're in residency, and even afterwards, because everybody needs a little bit of independent time to burn off extra energy. No matter what occupation in medicine you take, there's always going to be stress that comes with it. And it's a great way to get rid of stress and start the day off on the right path, or to end off the day with a little stress reduction technique. So I think making time for exercise and making time for yourself will definitely help to prevent physician burnout, which is a huge topic in and of itself. But I do that, and then I make sure I spend a lot of time, or as much time as I possibly can, with my family. So outside of work, I'll make sure that when I go home, I shut the laptop off for at least a good hour, 2 hours, get the kids' homework done, and then when everybody else gets occupied, then I'll peek back into it by the evening. And
so with the rapidly advancing changes in medicine, how do you stay on top of like all the changes like in family medicine, which is like a super broad specialty, and family medicine on top of that?
I guess the good and bad part about family medicine is you really don't get bored because there's so many things that walk through your office on a daily basis. But how do you stay on top of it so you're not behind? So I use the AAFP organization. They come out with a journal every 2 weeks. So either online or it'll get mailed to my house, and I'll read the journal. And that's my best way of staying on top of stuff. So they're constantly going through 3 major topics, and there's a lot of mini topics that they'll give you high yield information. But it's a good resource to get up-to-date information as things change. There's quarterly meetings we go to for our independent organizations that we are a part of, and through there they'll often give us updates and information of things that have changed with regards to guidelines. But a lot of it is just self-taught. I mean, you got to make sure you stay on top of the information as it comes out. So finding some sort of literature base that you can kind of routinely go to. And the biggest thing is just maintaining it. It's hard to make up for lost time. So you don't want to start and get too far behind because it's hard to get caught back up. but making it a ritual that every couple weeks just read something new, that way you can stay on top of it.
Over the past almost 10 years now, you've probably seen a few changes in medicine. How has it changed since you started, and where do you see it going in the next few decades?
So there's definitely been a big shift in regards to two departments. One would be the advent of the electronic health record, the EHR, and then two, the shift as far as reimbursement. Instead of going from quantity of care for the number of patients you're seeing on a daily basis that come in and out of your clinic, it shifts now more towards quality of care. So not only can you see patients, but can you make sure that you keep them out of the hospital, get their blood sugar under well control, keep their blood pressure down. The shift is making sure we're not just seeing patients just to see them, to collect copays and bill insurance, but to provide good quality care. So you may not see as many patients, but if you can give them good care, then you're going to prevent all these further outcomes later on down the road, which will help to decrease overall healthcare cost. And through that, there's a lot of advents of technology. So chronic care management teams that are within the primary care setting, telemedicine, so you have better outreach when the patient's not in your clinic, remote patient monitoring. So there's a lot of stuff now happening with My Health or Apple My Health Kit for integration of that type of data that's on your iWatch or blood pressure machines that go into your EHR. But the shift from quantity to quality, I think, is a big one. The EHR is still a work in progress. So the development of the electronic health record is nice in the fact that people can now have legible charts, but it's a matter of getting those charts completed in a timely fashion. And then the in-basket that's associated with the electronic health record can often be a big burden, and it's been a big cause of physician burnout. So there's other things like using remote scribes, using Google Glass Augmetics program for remote scribes. There's new technology. There's an organization called Suki, S-U-K-I, that's going to have some automated software where you just kind of talk like you're talking to Alexa, and it's going to transcribe the note for you. So technology is going to catch up, but right now the EHR has been a mixed bag as far as benefits for communication and integration of care, but the headache of the physician burnout and the physician overload from the in-basket and documentation.
And so last question, how do we become good doctors?
All right, so $1 million question. So I would say, by and large, by the time you get done with medical school, residency, and a few years into practice, your medical knowledge is going to be where it needs to be to treat any patient. But I would say bedside manner is by far, in a way, the way to become a great doc. Patients often already assume that you are a well-educated provider and that you're going to give them decent information with regards to health recommendations, but they want to like you. If you already have one hand on the door by the time you walk in and trying to get out, if you don't give them that extra 30 seconds to tell you what they did over summer, explain why they don't feel well, and really just get whatever bothering them off their chest, and if you rush them in and out, they're probably not going to come back. And so I think the biggest key for being a great doctor is just patience in the room, allow the patient to speak their opinion, and have great bedside manner. If you have that, I think by far and away you'll be a great doc.
Important things to keep in mind.
Yep.
Well, thanks so much, Dr. Chima, for being a part of this interview. Thank you guys so much for watching. If you have any questions for Dr. Chima, feel free to leave it down below in the comment section. I'll ask him and get back to you guys. And let me know down below in the comments as well who you'd like me to interview next. Thank you guys again for watching, and have a great rest of your day.